You might see there's a small change in the schedule. We are awaiting the arrival of Professor Shiv Sarin, who's on the way from the airport. However, in the interest of time, I will start. I'll also take this opportunity to congratulate the organizers to have such a grand success so far, and I'm sure more exciting talks are awaited tomorrow. So the mandate for me for the next 20 minutes is to take you to your clinical scenario wherein a patient who's sitting in front of you pulls out a report of an ultrasound which has fatty liver on it. What next? I think the discussion, the questions, or what are the next steps, what will happen next would largely depend on the type of patient that you have. And in our clinic, we may have a patient who's very proactive, who knows a lot about the subjects, who follows your instruction to the T, is very, very dedicated. As a doctor, I may contribute very less to his treatment. Always his reports are normal. On the other hand, I may have a patient who's very overconfident, who would have given me a lot of promises. Doctor, next time my HbA1c will be normal, I'll walk, I'll stop alcohol, I'll do this, that. But when I look back at history, probably none of that happens or has happened in the past. I may happen to have a very skeptical patient who's actually sitting in front of me, not for taking any medical advice or treatment, but rather there just to see whether his treating doctor has all the information that Google has provided him. He's just trying to check, doctor, this, that, is this okay? Just trying to check the knowledge of the doctor. On the other hand, I may have another patient who's very resigned, who's very disproportionately upset about his or her disease. And last, we may have a very casual patient in front of us who's actually sitting in front of us not because the patient wants any treatment there, but just because there is, somebody has asked the patient to sit there and they want some advice for that patient. However, the patient believes that medical advice per se will not help. I think we take this privilege to invite Professor Shiv Sarin on stage. Sir is actually one of the pioneers of hepatology in India, and it is my proud privilege today to speak in front of Sir. There's no better authority on this subject than Sir himself. So these are the different types of patients that we may see in our clinic, and I will go through all of these case scenarios one by one. But before we do that, let's have a very brief introduction on the topic of NAFLD, the spectrum of disease and the diagnostic criteria. When you look at the definition of NAFLD, there should be evidence of steatosis, which is either by imaging or histology, and we should have ruled out secondary causes of hepatic fat accumulation. NAFLD per se is a spectrum. It's a spectrum initially wherein there is just steatosis. So initially, there may be just steatosis. By definition, there should be at least more than 5% of steatosis to call it fatty liver. Then we move on to NASH, wherein there would be more of inflammation, hepatocyte injury that may take place, and later stages, obviously, we may have fibrosis and cirrhosis. So what's the prevalence of NAFLD in our country or otherwise? On an average, this is data world over, about 25, 1 in 4 would have NAFLD, that is just steatosis. The prevalence is slightly higher in the Middle Eastern countries, about 36%, maybe a little lower in the African countries, but on average, we see the 95% confidence interval between 22 to 28%. However, NASH is probably much less, about 1.5 to 6%, but the important question is how many of these patients with fatty liver actually go on to NASH, and when you look at data for that, it's important to see why those biopsies were done, because biopsy is indeed the gold standard to find out whether a patient has inflammation, whether a patient has evidence of hepatocyte injury. And if the biopsy was done for an indication like some liver symptomatology, then the prevalence may be as high as 60%. If the biopsy was not done for any particular indication like that, maybe as low as 5 to 10%. So overall, NASH is definitely, or NAFLD is definitely a very common disease. But it's important that we concentrate in this part of the definition that we have to rule out the secondary causes before we label a patient to have NAFLD. And when you look at the secondary causes of NAFLD, there are a lot of causes, but the common ones that we would probably see in our clinic We should rule out excessive alcohol consumption, hepatitis C, certain medications that are very commonly used, and if not them, then definitely the others as well. There are a lot of endocrine conditions that may be associated with NAFLD, metabolic syndrome being on top of the list, whether it's obesity, diabetes, dyslipidemia, metabolic syndrome, PCOS, and a lot of other pituitary or endocrine disorders, including hypothyroidism or hypopituitarism, may be associated with NAFLD. So with this brief background, I go back to the 5 cases that I said I would discuss, and let's meet our first patient. Our first patient is a very casual patient. She's sitting in front of us, a 67-year-old lady. She's got a BMI of 27. She's got past history of diabetes and hypertension ongoing for 12 years. Recently also had a coronary artery bypass graft. She also has some family history of hepatocellular carcinoma in her father, who was said to have cryptogenic cirrhosis. Probably at that time it was not diagnosed or whatever. We didn't know the cause of cirrhosis in that lady. And this lady is sitting in front, and she has a few questions. And she's there just because her children insisted, and because this report of fatty liver has come. It's grade 3. And she says, "Doctor, I don't want any big tests, but do you think this ultrasound report is really worrisome? And if so, can you do any non-invasive tests?" And people have told me to go for biopsy or something. Or can you tell any non-invasive markers that will help me, take, if at all this has to be managed further. So let's go back to evidence. Let's look at whether this report is really worrisome or not. And when we look at the data with respect to mortality of NAFLD, this is an old study, maybe in 2005, which showed that as fatty liver disease progresses in its spectrum, mortality may increase. But a more recent meta-analysis has shown that whether NAFLD or NASH, these patients are likely to die more than their normal counterparts, especially for NASH, and especially if you're talking of liver-related illness, then it's more NASH, but nevertheless, they do die. And the most common cause of death in these individuals would be cardiovascular disease, and that is independent of other metabolic comorbidities. Another of the top 3 causes of death that would happen in these patients would be probably hepatocellular carcinoma, and that's indeed the 3rd most common cause of HCC in the United States, the first being hepatitis infection and alcoholic liver disease. The incidence is rising very steeply, and when we have these patients who have NAFLD-related HCC, they usually have a shorter survival time, they usually have concomitant heart disease, they're older, and more importantly, they are likely to die because of this primary cancer rather than the other causes. This patient also gave history of her father having cryptogenic cirrhosis. There's some family history there. And there has been evidence over the past which has suggested that some of these patients who are labeled as cryptogenic cirrhosis may actually have fatty liver disease in them. And it may be just looking like burnt out disease, like sometimes in endocrinology we have patients who have clinical features of acromegaly. They look absolutely acromegalic, but when I do an MRI of the pituitary, it just shows an empty cella which was enlarged. Probably they had a big tumor there which has had an apoplexy, just showing a burnt out disease. A similar analogy here, patients may have cirrhosis which would have been probably because of NAFLD before, but is no longer there. So with this background, if we were looking at the question of the patient whether their NAFLD is really something to worry about, yes, the mortality increases, there's increased risk of cancer, especially in this patient who has family history, multiple components of metabolic syndrome. I wouldn't just let that report go. Talking about non-invasive tests, there are 3 aspects to it. When we look at quantification just for hepatic steatosis, when we want to quantify steatohepatitis, or we want to look at patients who've got severe disease, advanced disease, how can we look at non-invasively? For hepatic steatosis, it's just the degree of steatosis that we may get on imaging or that may predict the severity of physiological features. But when we want to know whether the patient has inflammation, you may decide that based on the number of components of metabolic syndrome that the patient has, or there may be newer markers like cytokeratin 18, which was a research tool, probably is coming into practice more rapidly now. However, the other non-invasive assessment tools for advanced fibrosis would be some kind of scores, NAFLD fibrosis score, FIB4 index, which is easy, simple clinical and biochemical markers are used, or we want to look at transient elastography, and these may help you predict whether the patient has advanced spectrum of NAFLD. They have fairly good sensitivity and specificities, and we're basically looking at sensitivity for them to be screening. So coming back to this first patient who had these questions and wanted to know whether it's worrisome or not, probably given the mortality, the morbidity, and the increasing prevalence of malignancy in these patients, it would be imperative to decide appropriately which patient you would like to screen further and which patient you can let go. But given in this particular patient, given her age, given her family history, given the multiple components of metabolic syndrome that she has, and the relatively grade 3, fatty liver that is reported on that ultrasound, I would not probably overlook that report. Let's meet our second patient, and this is the patient who is highly proactive, who follows all the instructions to the T, has always got the best of reports, and this is a 48-year-old school teacher who went for a master health checkup and came back with a fatty liver grade 2, doesn't have diabetes or hypertension, BMI is obese by Indian standards, grade 1, and has got dyslipidemia, which is diagnosed more recently. And the questions he has for his doctor: doctor, can I manage my fatty liver with lifestyle? If so, what diet would you recommend? And how much physical activity should I do? These are two very specific questions asked by this patient. So again, let's go back to literature and look at the impact of dietary modifications of NAFLD. There's again a lot of evidence, meta-analysis, individual studies, and overall what is the consensus is that if you lose 5% of your weight, up to 5% of your weight, you can definitely reduce the fatty liver or the NAFLD aspect of it. But for NASH, probably you need more weight loss, but still you can manage and you can reduce the inflammation and the fatty component of that liver by simple dietary measures. If they ask, we had an interesting talk today about low fat versus low carbohydrate, but per se for NAFLD, there isn't really much difference. No matter how you do it, you just lose your weight by your dietary alterations, and they have yielded similar results. How about exercise? So again, when we look at the evidence for exercise alone, so there is decrement as long as it's in early stages of disease. So if there's fatty liver, yes, by increasing your exercise by 60 minutes per week or by having a cumulative 150-minute per week exercise, there is decrement in serum aminotransferases. But if you're talking of inflammation, as of now, there's limited evidence that only exercise may reduce the inflammation bit of it. Talking of combined diet and exercise together, yes. Maybe because of the dietary component, maybe because of the exercise, or together the weight loss. So this was one study which showed that there could be reduction in the fatty liver component and the steatohepatitis component if there was adequate intervention in terms of diet and exercise put together. So coming back to this patient, we would answer yes, weight loss reduces hepatic steatosis by diet alone or in conjunction with exercise. You need to lose at least 5% if you want talking of reducing steatosis, but at least 7% if you want to reduce from the stage of inflammation, that is NASH. And exercise alone may reduce hepatic steatosis, but not, we don't have the evidence at this point if you're talking of steatohepatitis. Moving on to our third patient, and this is our overconfident patient who has promised several things in the past, who said, doctor, I'll control my HbA1c, I'll reduce my weight, I'll stop alcohol, and so on and so forth, and none of that has really happened. He's quite obese, BMI of 32, and has been taking alcohol for 10 years, and his ultrasound abdomen again picks up a grade 2 fatty liver, and we want to know what his questions are. And his question is, doctor, would you attribute my alcohol intake to this fatty liver disease that I have? And he's also read that alcohol is good for NAFLD. So, doctor, how much is okay? Let's go back to evidence again. How much can damage the liver with respect to NAFLD is only based on consensus guidelines. There isn't any way to actually prove it. And this is based on the National Institute of Alcohol Abuse. For most clinical trials that are done in NAFLD, significant alcohol consumption would be defined as more than 21 average standard drinks in men per week and more than 14 standard drinks in women. a standard drink would contain about 14 grams of pure alcohol. And anything of this sort, which has had at least 2 years prior to your diagnosis, is considered as significant, and you can put the blame on alcohol. Sometimes there are multiple reasons why, in addition to alcohol, which may actually compound the matter, but this much is the significant alcohol consumption. But what after diagnosis? So after diagnosis, definitely evidence is suggesting that heavy alcohol consumption should be avoided, and that is defined as anything like 14 drinks per week in men and about 7 drinks per week in women. But there were a lot of papers, and this is why that patient asked that, doctor, is alcohol good for fatty liver disease? And there are a lot of papers which were published, got the media attention, and such things somehow stay in the press for long. And they were suggesting initial studies that alcohol consumption actually reduces NAFLD, but more recently a meta-analysis has suggested that probably there was a confounding of these patients having low BMI, which was a protective factor, and at this point we don't really have any longitudinal studies to suggest this. And so going back to this patient, we would say that ongoing or recent alcohol consumption of more than 21 standard drinks per week in men and more than 14 in women would be considered significant while evaluating them for NAFLD, and they should not drink heavy amounts of alcohol, and that would be anywhere between 14 for men and 7 for women per week standard drinks. And at this point, there is insufficient data to make recommendations whether average alcohol drinking after having a diagnosis of NAFLD is going to improve or not. The evidence that was there before has come down by the findings of the recent meta-analysis. So let's meet our fourth patient, and this is the skeptical patient. This is the patient who's sitting in front of you not to take any medical advice, but rather try and find out whether his doctor knows enough, and what Google has provided information to this patient. He's a 42-year-old engineer. BMI is morbidly obese, 36. He's got diabetes for 2 years. He's got family history of diabetes in both parents. There's one child which is 12 years old. His ultrasound is showing fatty liver grade 3. And the questions that this particular patient has, and doctor, I was going through the internet and I'm worried about this fatty liver report that I've got, and doctor, do I need a liver biopsy? Will my child also get it? Is there a role of familial screening? So talking about liver biopsy, the evidence is clear. I mean, there are probably 2 main indications why a patient with NAFLD would require liver biopsy, and the first is when you are suspecting that this patient has more advanced disease in terms of fibrosis or steatosis, and that would be predicted by any of these scores that I talked about before, or you would need a liver biopsy to find out any of those secondary etiologies that I showed before, and if you want to rule them out, then it would be useful. However, role of familial screening, I mean, it depends on the child's BMI, and if the child is obese, the recommendation is biannual screening with the ALT and AST starting as low as age of 10. And heritability of NAFLD has been controversial. There are papers which were for it, for against it. There's Indian data which suggests for that there is importance in family history of NAFLD and cirrhosis because of NAFLD, and there is a higher risk if you have a family history. So for this patient, we would say that liver biopsy should be only considered in those who have higher risk of developing NASH or cirrhosis predicted by the various clinical, biochemical, and the radiological tools, and systematic screening of family members of NAFLD is not recommended currently. And coming to our last patient, who's the resigned patient who says was disproportionately upset because of the diagnosis. She's a 38-year-old housewife, morbidly obese again, and just on an annual health checkup, she's been diagnosed to have diabetes, dyslipidemia, and fatty liver. And she's very clear, doctor, I don't want to take any medicines. And the questions she has, she's very upset with her diagnosis. She's saying that, doctor, will I have to live with these forever? Can't my disease be cured? I've gone to several doctors. They said you have to start medicines, you have to lose weight, you have to control your disease, but can it be cured? I'm willing to do anything that you say. Can diabetes and fatty liver be reversed is the question. We heard about Dr. Roy Taylor in the morning. We know about this twin cycle hypothesis, reducing liver fat, reversal of diabetes, a lot of papers, and more recently the direct study, which has indeed showed that good weight loss would and possibly reverse diabetes in a significant proportion of patients, maybe 46% in the intervention group. You just need to make sure that the diabetes is well controlled and the weight is well lost. But for NAFLD, per se, yes, bariatric surgery is this particular patient morbidly obese, and there is evidence that there could be normalization of the histology of liver if adequate weight loss was achieved with bariatric surgery. But what about diet? There is a small paper that I found. This is from the Indian Center, and wherein they had good intervention in terms of a diet and an exercise intervention program in people who are highly motivated, especially before liver donation, and they would do anything that you say at that time. They just want that clearance from the endocrine perspective that they are okay. And in this particular study, they lost about 7 kgs, but there was normalization of liver histology in 7 out of 16 donors. So probably with diet and exercise, maybe if you have adequate weight loss, you may be able to reverse. And there were probably 3 cases of mild inflammation also, which they reportedly reversed. So for this patient, diabetes cure without bariatric surgery, with more recent evidence from the direct study, is seemingly becoming a reality if they lose adequate weight, and maybe data will emerge further for NAFLD. The key is good diet plan and long-term motivation. What do the guidelines say if the patient has an incidental finding of fatty liver disease? So in patients who don't have other symptoms and signs attributable to liver disease, we would probably just follow them up. But if they have, and we make sure that we assess for their metabolic risk factors, and we treat them as for any other patient. Otherwise, incidentally finding in an unsuspected hepatic steatosis would just warrant follow-up. So I'll close with this, and be happy to take questions at the end. Thank you.
2 questions. First is the fibroscan as an investigative modality in NAFLD or fatty liver diseases. And other is metformin in grade 1 fatty liver for preventive purposes, or has it been approved for curative purposes? If at all, what is the dosages?
Sure. So answering your first question, so I mentioned about transient elastography. Now there are 2 types of modalities that we can use. One is a fibroscan, and another would be an RFE scan. Both have slightly different principles in use, but they will be used to find out probably predict the amount of fibrosis that is there, and that will give you an idea whether you should go for a liver biopsy or not. The principles are slightly different. RFE scan could be used for other organs as well. We at CMC Vellore use the RFE scan. I think the question on treatment would be answered in the next lecture, which is on treatment of NAFLD. So I'll leave that.
The elastography is the same as the fibroscan, right?
Yes, the same principle. So
it's ultrasound method,
it's
or
through the similar probe.
Parameters, sonographic criteria have been laid down for this?
Yes, definitely.